Oh, I recall. Sorry about that. So, good morning, everyone. And it's our pleasure today to have Professor Adnan Qureshi, who is a professor of neurology at the University of Missouri in Columbia. Uh, Dr. Qureshi is very well known for his extensive research, especially in the stroke field and cerebrovascular neurological disorders. And it's our pleasure today to have him. And he will be focusing his talk on intra-arterial treatment of migraine and subarachnoid hemorrhage related headaches. Dr. Qureshi, thank you so much for being with us this morning, and uh, we are very happy to have you.
Well, first of all, thank you so much for inviting me. As we were talking about that, I came to your university years ago. So, but now with the Zoom technology, we can actually meet with each other without being there in person. So I thought I'd talk something about a very emerging topic, and that's actually intra-arterial treatment of migraine and subarachnoid hemorrhage-related headaches. These are my potential conflicts of interest. Now, the story of intra-arterial treatment and migraines actually starts with a branch called the middle meningeal artery, which is actually a branch of the external carotid artery and the internal maxillary artery. And then, when we were actually training in neurology, we never even knew about this branch. And over the last almost 3 decades, this branch keeps actually increasing in its significance. So the branch actually comes off the middle meningeal artery. The middle meningeal artery actually subsequently divides into the anterior and posterior dural branches that supply the dura over the brain. Now, how does middle meningeal artery relate in migraine? So, the middle meningeal artery actually is innervated by the trigeminal nerve ganglion. The trigeminal nerve ganglion subsequently releases the calcitonin gene-related peptide that leads to vasodilation in the middle meningeal artery. And that vasodilation leads to activation and sensitization of the perivascular sensory efferents. And that actually is implicated in the genesis of migraine headaches. Now, in interventional world, the middle meningeal artery has been known, not for migraines, but actually for embolization of tumors like meningiomas and embolization of arteriovenous fistulas, dural arterial fistula, and more recently with chronic subdural hemorrhages. And before embolization, it was not uncommon practice to actually give lidocaine into the middle meningeal artery to make sure that a transient anesthesia in the middle meningeal artery does not lead into any neurological deficits before you permanently occlude the artery. So there has been precedence in giving anesthetic agents into the middle meningeal artery. So the journey starts on almost 12 years ago when we started actually saying that there are patients who have headaches that are because of either dural inflammation or dural stretch. And what about if we give them intra-arterial lidocaine and whether that would actually improve their headaches? So we started with patients who had headaches and were going to get an angiogram anyway. And we actually gave them lidocaine into the middle meningeal artery. So initially, we would put a microcatheter into the middle meningeal artery. And once we actually made sure that there were no branches of the middle meningeal artery that actually supply the ophthalmic distribution or any intracranial contribution, we gave them lidocaine and combined it with steroids, methylprednisone, so 40 milligram of lidocaine and 20 milligram of methylprednisone over 5 minutes. And then, interestingly, within 5 minutes, the patient reported there was resolution of the headaches. So some pathophysiologic confirmation that lidocaine infusion or any anesthetic infusion in the middle meningeal artery can actually influence or ameliorate the headaches. And the effect actually lasted somewhere between 5 to 8 hours. And even at 24 hours, the patients said their headache was much better than pre-treatment. So clearly something that could be explored further. So then we actually started doing more systematic evaluations, and we started treating patients who had intractable headaches and patients who had headaches that actually had tried numerous medication without adequate relief. So, and most of them actually were already using opioids before they actually were referred to us. So the definition of intractable headaches was the one that actually was defined in previous recommendations. These are actually intractable headaches, failure of non-steroidal medications, combination analgesics, even oral or parenteral opioids. And this time we actually tracked the severity of headache using the numeric rating scale, pre-procedure and all the way up to 7 days. And then essentially we treated these patients giving 45 milligram of lidocaine in each of the middle meningeal artery. And here you can actually see the severity of the headache pre-procedure and post-procedure up to 7 days. And essentially the headache patients were headache-free for the next 48 hours. And even up to 7 days, the severity of the headache was never the same as the severity pre-treatment or pre-infusion. And these are actually like a different patient, but.
And are you giving us consent to videotape you or to ask questions about your headaches?
Yes.
Okay. Can you describe where your headache is located right now?
It's mostly in this area.
Mm-hmm.
It does kind of wrap around a bit or go back, but it's on this right at the base of my spine here.
Okay. And if you have to give me a number, 0 out of 10, how bad is your headache right now?
Right now it's an 8.
Okay. And then what does your headache feel like?
It feels like ice picks,
Okay.
but with a wave to it that it kind of move, just
Yeah.
sweeping.
Yeah. Okay. Do you feel like you're gonna throw up?
No, not right now. I have felt like it, but no.
Okay. Is bright light bothering you?
Yes.
Is loud noises bothering you?
Yes.
Do you feel any dizziness or lightheadedness?
No.
No. Okay. And how about your vision? Any blurry vision?
Yeah.
Okay. And just confirming again, you do not have history of migraines, correct?
Not since I was 19 and I'm 62 now.
Okay. Great. Okay.
63.
Okay.
And this is after treatment.
D-lock.
You're okay being on video to compare this to the pre-procedure video?
Yes.
All right. So how's your headache right now?
It's better. It's probably about a 4.
Okay. And how was it before the procedure?
It was a 9 or 10.
Yeah. Okay. And is it in the same location?
Yeah, at the top of my head.
Top of your head. And can you describe quickly the headache to me, please?
Kind of like just pounding. It's yeah, it's different than before.
Okay. And do you have any light sensitivities at this point?
No.
Photosensitivity, bothering sounds?
I don't know about the sound so much, but the light.
Light is bothering you?
Yeah.
All right. Do you have any blurry vision?
No, not that I can tell.
Okay. Nausea?
No.
All right. All right. And overall, do you think that this improvement happened during or after the procedure?
During the procedure.
During the procedure.
Yeah.
All right. Sounds good. Thank you.
No D-lock.
So there you can actually see pretty dramatic improvements immediately after the procedure. Then we actually started extending to patients with status migrainous. So patients, you actually have a history of migraine and now have a very severe migraine headache that actually hasn't been able to or wasn't resolved with the standard treatments. And then we would actually inject 50 milligrams of lidocaine in the middle meningeal artery. And you can see the middle meningeal artery, the branches, the dural branches, with the microcatheter that's actually in position in the middle meningeal artery for the initial angiogram to confirm for confirmation of the artery and also giving the lidocaine. And then we treated these patients, and these are patients who had very severe headache with no remission. with standard treatments, including opioids. But we wanted to do something different. We wanted to see how long the benefit actually lasts. So, we saw that the benefit was actually still apparent up to 7 days, but we wanted to do a little longer study. So one way to test that is the MIDAS, which is the Migraine Disability Scale. So it looks at the disability and the components of disability 3 months prior to the procedure and 3 months after the procedure. So here we actually collected this data in these two patients. And essentially, you all are aware of the components of MIDAS. And it's looking at various components here. And if you break them down individually, you can see that almost all the components actually got better in the 3 months after the procedure as compared to pre-procedure. And if you look at the total score, one patient actually reported a score of 30 in the months preceding the lidocaine infusion and 3 in the months preceding the lidocaine infusion. The other patient had 90 and still 3 months after the procedure was down to 55. And if you look at disability, so if you classify the severity of disability on the MIDAS, one of the patients actually had little to no disability as compared to severe disability before the infusion. And the other person, even though the total MIDAS score was lower, still actually ended up being categorized as severe disability. But nonetheless, actually, you can look at the frequency of headaches was much lower in the 3 months. And similarly, the severity of headaches was lower in the 3 months after infusion. Now we've actually done our study on 10 patients, done the pre and post MIDAS before and after treatment. And you can see in the red bar is the MIDAS score before the treatment, 3 months before the treatment. And in the yellow bar is 3 months after the treatment. And you can see it's consistently lower after treatment at all the 10 patients. So clearly a very consistent benefit that is seen in all the patients regardless of the initial disability on the MIDAS scale. And if you look at the categorization, so if you say, well, whether they had severe disability, all 10 patients had severe disability according to MIDAS before the treatment. And if you look at the disability after treatment, the 3 months after, 50% of them or half of them actually were categorized as little or no disability. So clearly a pretty dramatic effect, a 50% response on the severity of disability 3 months after the procedure. And interestingly, we followed these patients all the way to a median period of 9 months. Now, 4 of these patients were taking opioids before the infusion, and 3 of these patients were able to give up the opioids after treatment. So it's almost like an opioid sparing effect as well. Now, obviously, it's just us, so it's very important that other people try the same treatment and come up with the same response. And now that this treatment has actually expanded, there is actually other studies coming out confirming the result that we had observed over the last 12 years. For example, in this study, they looked at patients, and this time they actually categorized the reduction in headache-free or headache-free days per month. So they took 45 patients in 2 centers, and then essentially you can see that 60% of the patients had a 50% or greater reduction in headache days per month. At 2 months, again, still around 40% had the reduction. By 3 months, the proportion had decreased. But even at 3 months, 20% of the patients had a 50% or greater reduction in headache days as compared to pre-treatment. So the effect actually is persisting well beyond the half-life of lidocaine and all the way up to 3 months. And then again, another group doing another study, and again confirming the results that patients with refractory migraine, and this is the refractory migraine definition, is a pretty intense definition. It is really requiring patients to fail at least 4 medication before they were considered. And they also used lidocaine in combination with methylprednisolone. And 6 out of the 9 patients actually had, or 5 out of the 9 patients had complete resolution of the migraine headaches, and only 4 actually had some recurrence of migraine headaches. So now it's not just us. Many people have reproduced the results that intra-arterial lidocaine in refractory migraine can actually result in a sustained benefit at least up to 3 months post-treatment. Now, it's actually interesting that, when we look at migraine treatments, kind of classified into two groups, abortive treatment and preventive treatment. And abortive treatments are really to treat the acute headaches. So, you have a non-steroidal inflammasome, you have the triptans, you have the serotonin receptor agonists, steroids, the ergots, and then you have the preventive treatments that are beta blockers, calcium channel blockers, many of the anti-epileptic medication, the calcitonin gene-related peptide inhibitors, Botox. But intra-arterial lidocaine is surprisingly acting in both capacities, both as an abortive treatment and a preventive treatment. So how does it work? Well, we know it's doing something, but what is the presumed mechanism of action? So we actually talked about that there is this perivascular unmyelinated C fiber that surround the middle meningeal artery. And lidocaine is a sodium channel blocker. So when you give lidocaine in the middle meningeal artery, it stabilizes the nerve membranes. It reduces or delays nerve polarization and reduces the ectopic discharges. And presumably, that action at the level of the perivascular unmyelinated C fibers is actually causing the amelioration in the headaches. But then, lidocaine's half-life is only 90 to 120 minutes. The benefit is clearly lasting 48 hours or longer. So there's a mismatch. So the biological half-life or the pharmacological half-life is not corresponding with the therapeutic benefit that actually extend much longer. And how do we explain that? And one theory is that it is central desensitization at the level of the thalamic neurons. So these neurons with consistent pain or severe pain go into a state of hypervigilance or hyperactivation. And when you give a break in the cycle of pain, you break that cycle, allowing these neurons to recalibrate and actually reset to baseline neuronal activity. So actually reducing the pain threshold and breaking the cycle of pain beget pain. Now we have been using very low doses. So if you look at the doses that have been used of intra-arterial lidocaine, the much higher doses have been used in other intra-arterial applications, up to 5 milligram per kg. And the toxicity of lidocaine does not start in animal studies up to 6 milligram per kg. So really, you could go easily up to 5 milligram, 500 milligram, without actually exceeding the toxicology or the toxic threshold that has been established in animal studies. Now, one of the problems is placebo effect. We know that with migraine patients, placebo effect is a major issue. And that has been made obvious with the Botox trials. So in the Botox trials for the PREMPT study, you had these pain injections or these target injections, but one group got the target injection and got Botox, and the other group just got placebo. And if you look at the response, which is a 50% reduction in headache frequency over 24 weeks, 47% of the patients had the benefit when they got the botulism injection, but 35% of the placebo group also got a benefit. So I think there's always this concern of a placebo effect anytime we come up with a therapeutic intervention for migraine. Now, it is actually an invasive treatment, and whether patients will actually accept an invasive treatment, that's something that remains to be seen. I think there is some precedence that patients have actually accepted more invasive methodologies like decompression of the subarachnoid and supraorbital nerves by endoscopic and transpalpable approaches for migraine. And I think that acceptance of invasive procedure really depends on the response, because many of these patients have very severe symptoms, very disabling symptoms. So it may actually still be an option. Now, one thing I actually wanted to mention is that the nerves are supplied by blood vessels. And interestingly, since nerve ultrasound became available, people started doing nerve ultrasound of various nerves. But if you give them ultrasound contrast, you can actually visualize blood vessels as the ultrasonic contrast goes through the blood vessels. And you can actually see these pulsating contrast right next to the nerves, the vasa nervorums. So essentially, you can see that hyperintensities around the nerves themselves, the vasa nervorums. So the blood vessels actually do supply the nerves. Now that actually creates a very interesting possibility. Can you give something intra-arterially and yet affect the function of the nerves? And if you remember, the trigeminal nerve actually does have a role in innervation of the middle meningeal artery. Now, the middle meningeal artery actually supplies the branch before it divides into the anterior and posterior dural branches. And that branch actually goes towards the foramen of Weil, where the trigeminal nerve ganglion is actually located. Now, you can actually just ask for a sensory numbness, but that may not be enough if you really want to have an objective evaluation of what happens to the trigeminal nerve activity when you inject intra-arterial lidocaine. We have to do electrophysiology. So you have to do evoked potentials, the blink reflex or the electrophysiologic correlate of the blink reflex, and actually you can get the blink reflex before and after treatment. So in the upper column, you can actually see the trigeminal nerve activity before treatment. And the column before, you can actually see after injection of intra-arterial lidocaine. So there is clearly electrical suppression of the trigeminal nerve activity after giving intra-arterial lidocaine into the middle meningeal artery, presumably mediated through the branch of the middle meningeal artery that supplies the trigeminal nerve ganglion. And here actually is with the bone in, so you can actually see the middle meningeal artery. And then you see the small branch that goes anteriorly towards the foramen of Weil and divided into multiple small branches that actually innervate the trigeminal nerve ganglion at the skull base. So we actually tried this approach in patients with refractory trigeminal neuralgia. So as we all know, the trigeminal neuralgia is a very disabling disease. But interestingly, one patient was treated with intra-arterial lidocaine before actually evaluated the patient just for headaches. And the patient actually reported to me that, my trigeminal neuralgia also got better. So we started using that approach and we tried in 3 patients who had refractory trigeminal neuralgia. And many of them actually even had percutaneous ablation treatments. And interestingly, the pain severity actually improved for the next 3 to 5 days. They actually had a consistent improvement in the hyperalgesia, which you all of know is a component of the trigeminal neuralgia, and all the dermatomes. Now, in 1 month, the patient's symptom did actually come back to baseline severity. So we are not seeing the same sustained effect, but nonetheless, we actually have a proof of concept that trigeminal nerve activity is suppressed with actually clinical correlates when you inject lidocaine into the middle meningeal artery. And interestingly, the health insurance company Adnan actually acknowledged it as one of the therapeutic approaches for refractory trigeminal neuralgia. Well, what about subarachnoid hemorrhages? Well, subarachnoid hemorrhage is actually diagnosed with severe headaches. Patients with subarachnoid hemorrhage have severe headaches during hospitalization. In fact, most patients, 75% of the patients with subarachnoid hemorrhage need opioids during the ICU stay for management of headaches. So headache is a very severe issue in subarachnoid hemorrhage. And yet, some components of subarachnoid hemorrhage related headaches actually are similar to migraine. So we actually started treating subarachnoid hemorrhage patients. Initially, we treated 7 patients. 4 of them had aneurysmal subarachnoid hemorrhage, and 3 of them had non-aneurysmal subarachnoid hemorrhage. And 1 patient we did not treat, but we collected all the data on the headaches to act as a control. So this is actually a daily chart looking at severe headaches. So there is actually a definition of severe headaches for subarachnoid hemorrhage patients, which is defined as 2 or more days with maximum point scores of 8 or greater or need of 3 or more different analgesic agents for 2 consecutive days. So the 7 patients, the red component is actually where they would actually meet the definition of severe headaches. For most of the days, they did not meet the definition of severe headaches. The control patient, the bottommost, met the definition of severe headaches for all of the days except one day. So that actually does take you a starting contrast in patients who got intra-arterial lidocaine after subarachnoid hemorrhage in the middle meningeal artery and their headache characteristics as compared to the patient who did not. Now, one of the interesting things was in this particular group of patients, we started doing something interesting. We did the initial angiogram of the middle meningeal artery, but then we actually started doing serial angiograms as we injected lidocaine to see what is really happening to the arterial caliber of the middle meningeal artery. And what we started noticing was there is vasoconstriction of the middle meningeal artery as we keep giving intra-arterial lidocaine, which is actually interesting and paradoxical. Whatever data we have with intra-arterial lidocaine and the other vessels suggests that there is vasodilation with lidocaine. But here, there's actually vasoconstriction, and it's consistent. Now there is several studies and much larger studies by our group and our group showing there is a vasoconstrictive response in the middle meningeal artery when you give lidocaine. Whether it's true vasoconstriction or these vessels were actually vasodilated and you simply ameliorated the vasodilation, I think that actually remains to be seen. And then there was a much larger study treating subarachnoid hemorrhages and the headaches related to subarachnoid hemorrhages with intra-arterial lidocaine. And that was actually the National Bulgarian Register. So it's actually interesting that there's around 7 million people living in Bulgaria. But there's only one center where all the subarachnoid hemorrhages are transferred for aneurysmal subarachnoid hemorrhages. So that just represents a very large number of patients coming to one particular center. So 58 patients were treated in that series. And here you can see the baseline characteristics. Most patients will be considered good grade because you needed to have an evaluation of the severity of headache before treatment. So you can evaluate what happened post-treatment. But most patients actually had extensive subarachnoid hemorrhages. So if you look at the CT scan, Fisher grade 3 and 4 were the main location on the extent of subarachnoid hemorrhages. So that means there was extensive amount of subarachnoid hemorrhages in the basal systems in these patients. So the treatment, actually, the aneurysm treatment, so this is actually the distribution of aneurysm treatment. Most patients were treated within 48 hours of the onset of subarachnoid hemorrhage. Now, intra-arterial lidocaine was given at the same time. So once the aneurysm was treated, after treatment of the aneurysm with endovascular treatment, the same microcatheter was actually placed under fluoroscopic guidance into the middle meningeal artery, and lidocaine was actually administered. And most patients actually had bilateral infusion, except in a very small minority, only the side where the subarachnoid hemorrhage was located or the aneurysm was located got lidocaine. So this is actually the doses of lidocaine that were used. That actually ranged between 5 to 50 milligram, but mainly it was really 10 to 20 milligram of lidocaine, so lower dose than what we have used in our studies. But that was actually used in these subarachnoid hemorrhage patients. Now, the angiographic response is also categorized, and now we have a classification scheme. So really, one is no change. Second is that there is distal branch narrowing. Third is that a distal branch narrowing, and there is also a decrease in the overall vascularity on the serial angiogram. And then there is actually narrowing of the anterior and the posterior dural branches. And the most extensive response is that the narrowing of the proximal middle meningeal artery prior to the division into the anterior and posterior dural branches. And you can actually see that almost all patients had a vasoconstrictive response. All patients had a significant vasoconstrictive response, as you can see with this grading scheme, that they actually definitely had a vasoconstrictive response in the distal branches all the way into the dural branches after injection of intra-arterial lidocaine. So a consistent vasoconstrictive response, whether the therapeutic effect is related to the vasoconstrictive response or not, is something that is being evaluated at this point. And again, whether it's vasoconstriction or reduction in existing vasodilation is something to be seen. But the most important is what happened to the headache. That's what the reason. So if you look at the severity of headache, where 0 is no severity and 10 is the worst possible headache, and you can actually see the severity of headache before treatment or lidocaine injection, and then the follow-up up to 10 days, and a consistent reduction in the severity of the headaches in these 58 patients, all the way up to 10 days. Now, if you define the severe headache, so if the severe headache, again, using the existing definition, the 2 or more days of headache with maximum pain scale of 8 or greater, or need for 3 or more analgesics, only 3 of the 58 patients met the definition of severe headache. This is an extremely impressive response for subarachnoid hemorrhage patients. All of us have managed these patients in the ICU, and we know the amount of severity of headache, the amount of analgesic treatments, the opioid these patients require. So 3 of 58 is a very impressive response in subarachnoid hemorrhage patients. Now, it was actually interesting that our colleagues in Bulgaria, they actually did something interesting. They also measured the severity of nuchal rigidity, which actually is a sign of meningeal inflammation. And they actually graded it 3 meaning severe and 0 meaning no nuchal rigidity. And they actually graded it pre and post intra-arterial lidocaine infusion. And surprisingly, you can actually see that there is actually improvement in the nuchal rigidity post-treatment. And it's a consistent improvement that's measured all the way up to 6 days after intra-arterial lidocaine. So neck rigidity has been used for meningeal inflammation, not just in subarachnoid hemorrhages. We're also familiar with using it in meningismus and meningitis. But nonetheless, there seems to be at least some benefit on meningeal inflammation with intra-arterial lidocaine, which actually does suggest that there are some studies showing that lidocaine actually does have an inflammatory effect. And obviously, some of the inflammation is mediated through the trigeminal nerves that we know can be affected with intra-arterial lidocaine. And there is actually a real patient. You can see the severe neck rigidity before treatment. This is after treatment. And you can see a very significant improvement in the neck rigidity and the headaches after treatment with intra-arterial lidocaine in the subarachnoid hemorrhage patients. Now, one thing that came completely unexpected. Now, most of these patients are mild to moderate severity on the clinical severity, but actually have a lot of subarachnoid hemorrhage in the basal cisterns. Most of them are grade 3 and grade 4 subarachnoid hemorrhages on the Fisher grading scheme. Now, if you remember that one of the complications of aneurysmal subarachnoid hemorrhage is cerebral vasospasm and cerebral ischemia. And obviously, the patients that have the larger amount of blood in the basal cistern are at the highest risk. So if you look at this profile, you would say that at least 30% of these patients, not even if more, should actually develop vasospasm and cerebral ischemia. But actually, if you look at this series in 58 patients, only 3 patients developed vasospasm that required endovascular treatment. 5.1%. So that's a very low rate of cerebral ischemia in aneurysmal subarachnoid hemorrhage. And if you look at the CT scan, so 46 patients actually had a follow-up CT scan. Only 4 patients had a new hypodensity on the CT scan. Now, whether that's just patient selection or there is a truly neuroprotective effect of intra-arterial lidocaine on cerebral ischemia and cerebral vasospasm in aneurysmal subarachnoid hemorrhage is something that needs to be defined. Now, when we first presented these results, somebody said, what happens to the transcranial Doppler velocities in these patients after giving intra-arterial lidocaine? And interestingly, we had one patient we treated that actually had ultra early vasospasm. So patient already had vasospasm before we treated the aneurysm and before we gave intra-arterial lidocaine. So the Lindegaard ratio was almost 6 on the side where the aneurysm was before treatment because the patient already had vasospasm. And we gave intra-arterial lidocaine, no other treatment for vasospasm because patient was still asymptomatic. And we actually continued serial monitoring of the transcranial Doppler ultrasound. And if you look at the Lindegaard ratio, in the next 3 days, there is a significant reduction in vasospasm. On the side, there was vasospasm with intra-arterial lidocaine. But essentially, over the next 3 days, it eventually returns to the pre-treatment level. So at least there was a transient response in amelioration of cerebral vasospasm after intra-arterial lidocaine in this particular patient. And since trigeminal nerve ganglion activity has been implicated in cerebral vasospasm in aneurysmal subarachnoid hemorrhage, perhaps it's the trigeminal nerve ganglion activity suppression that mediated this temporary alleviation of vasospasm that lasted for a few days. So there may be some intracranial effects of intra-arterial lidocaine, presumably mediated through the trigeminal nerve activity. Now again, reproducibility in other centers is the key. So it shouldn't be just us saying that. Other people should be able to reproduce the results. And now other studies have come up confirming the benefit on headache in aneurysmal subarachnoid hemorrhages. And this particular study looked at patients, looked at controls, the patients that did not get any intra-arterial lidocaine, and in the blue bar and the green bar are patients who got intra-arterial lidocaine with or without methylprednisone. And essentially, if you look at the first day after treatment, you can see there is a significant reduction in headache burden as defined by a cumulative visual anorganic score measured at multiple hours. If you look at between day 1 and day 7, again a significant benefit in the patient that got intra-arterial lidocaine with or without methylprednisone as compared to the group that did not. And even between 7 days and 1 month, the benefit continues to persist. So, and on the other hand, you can see that for the first month, patients that get intra-arterial lidocaine with or without methylprednisone actually continue to have a significant benefit in patients with subarachnoid hemorrhage when it comes down to headache severity. So what now? I mean, I think that we have data, but it's not complete. It's still case series. We don't really have a randomized clinical trial. So obviously that is the next logical step, to do a randomized trial and do multi-center registries so that we can demonstrate both reproducibility of results and also which patients really benefit. So I think that, when we talk about migraine and subarachnoid hemorrhages, we're talking about a broad patient population. And I think it would be naive to say that every patient will benefit, particularly when it comes down to migraine patients. So we really need to define which patient groups are really going to benefit, which patient groups are going to have a sustained benefit. But actually, this is one unique opportunity, but it's not just research, but there's actually opportunity for development as well. And essentially, if liquid lidocaine that has a biological half-life of 90 to 20 minutes can create such effect, what are actually lidocaine that can be given, that can be delivered in a sustained manner? It can actually be an implantable lidocaine that actually can be given in the middle meningeal artery and is released or degrades over a period of weeks. And this is actually already happening. These devices are out there and are entering clinical trials. And basically these are like microspheres. You can inject it through the same microcatheter you're giving the liquid lidocaine. They actually get deposited into the middle meningeal artery and they keep degrading and releasing lidocaine over the next 30 days. And this is actually the first patient that has been treated already. And you can actually see they put a microcatheter in the middle meningeal artery, and you keep injecting these particles till it actually fills the middle meningeal artery. Now, this is a temporary occlusion because these are biodegradable. And over the next few days, these will all completely degrade and the artery will become patent again. But the lidocaine itself has been released over days as opposed to giving a single injection. Again, it's early and more results to follow. Whether that actually will give a more sustained therapeutic benefit as we go forward, clearly going to be a subject of more clinical study. Now, obviously, some people actually are advocating permanent occlusion of the middle meningeal artery. So you already have occlusive agent that we've used for arteriovenous malformation. More recently, subdural hemorrhages. Why not just block the middle meningeal artery completely? And it's possible that that may be a sustained benefit. The two things that we have to be careful about. When you actually embolize the middle meningeal artery, the liquid embolic agent will not go all the way into the smallest branches of the middle meningeal artery. Over time, the meninges is a very vascular structure. It's a highly vascular structure. We have seen it at dural arteriovenous malformation. It's extremely vascular. And other supply to the middle meningeal artery will start forming these distal branches again. So these distal branches will reappear through collaterals. But the proximal portion where you could give some more embolic agent is gone. You blocked it. So the gateway is actually closed and there is no entry into these small branches that have re-emerged and may actually result in recurrence of headaches. I do want to actually leave a certain level of caution. I think that, overall the complication rates have been extremely low and we've been fortunate, but I don't want to underestimate the risk. The middle meningeal artery does actually have a branch, the petrusal branch, that actually supplies the facial nerve next to the stylomastoid. It actually does have a trigeminal nerve supply. And sometimes the middle meningeal artery may be the supply to the ophthalmic artery. So we have to be careful every time we're giving temporary or permanent occlusion of the middle meningeal artery. I'm actually going to conclude here. I just wanted to save some time for discussion. I think that, we are at a very interesting cross-section in migraine treatment. The middle meningeal artery route may provide a new therapeutic approaches for a variety of diseases, such as refractory headaches, status migrainous, headaches in subarachnoid hemorrhage, and perhaps even refractory trigeminal neuralgia. But I think as medical professionals, we must support future studies to provide adequate scientific evidence for appropriate identification of patients who can benefit and a careful assessment of risk-benefit ratio with these promising approaches. Thank you.
Thank you so much. That was fascinating and very interesting to learn about. Please, everyone, find the CME code in the chat box and put your questions in the Q&A section. So we have one question here. The first question is in your intractable headache migraine study, did you evaluate the presence of medication overuse headache pre-treatment that may be an additional target contributing to the benefit?
Excellent question. So we are actually planning a prospective study right now, and medication overuse headache will be an exclusion criteria. But that's a totally different category of patients. So I think that, in the series so far, we haven't made that exclusion. I can say that most patients did not have medication use, but we haven't used the standard definition. So as we go forward, yes, that will be an exclusion criteria that those patients will not be included in the new future studies.
I do have a question actually related to that. And if you have sometimes like you have patients who may have kind of a gray zone diagnosis, like they can be having, like, let's say migraine, and they have history of, let's say, idiopathic intracranial hypertension. Would it, like, one of the exclusion would be like having a possibility of another type of headache for including them in the study, or?
So this is actually an interesting, a very important question,
Mm-hmm.
because as we know, that migraine patients may have more than one headache,
Mm-hmm.
and that we see that. So as we narrow the patient population down, so we are actually in planning a clinical study right now. So those patients where migraine is not the sole cause will be excluded, so that there's a clear identification of the patient population and a clear mechanistic action. Now, in Bulgaria, they're also going to start measuring the calcitonin gene-related peptide concentrations pre and post procedure. And in the study that we are planning will be the same. So we will have, I think that we have to understand more of the mechanistics of the benefit. So not only just narrow the patient population down, but try to narrow the mechanistic or the mechanism, the underlying mechanism as well, so that the therapy itself is directed. Now, there is some thought that perhaps the dose of lidocaine shouldn't be a fixed dose. It should be based on the angiographic response. Because you can see vasoconstriction in some individuals with just 10 milligram, in some individuals it takes 50 or even 150 milligram. So perhaps it should be individually tailored, and whether the calcitonin gene-related peptide concentrations is another stratification variable. I think these are things that would have to be evaluated as we go forward.
Thanks a lot. We do have a few more questions in here. So first, thanks a lot for the talk and this new promising approach. Did you just try to deliver the steroids alone compared to lidocaine? And do you think steroids work alone?
So it's very astute of you to notice that initially we started with lidocaine and steroids. But the biggest critique became, what is working, lidocaine or steroids? So we said, okay, using both is going to confound the picture. So let's just use lidocaine only. So all our subsequent studies have been with lidocaine with a consistent benefit on the severity of headache. Now, we haven't used steroids in itself alone. And whether giving steroids actually helps the effect is really more of a placebo effect. So that's something that has to be evaluated. I think that we focused on lidocaine because there was extensive literature on intra-arterial delivery of lidocaine as compared to other agents. Because as you know that there's actually other agents also, not just steroids, but actually even more longer-acting amides. But there is no real data on intra-arterial administration of those amides. So then you have two new things. One is actually the agent is new, and secondly, the disease is new. So we wanted to go in a stepwise fashion. We just narrowed it down to just the disease being new and using an existing agent that had at least a certain level of experience in intra-arterial delivery.
And in relation to this question, like there is kind of a comment or mentioning that the delivery of the middle meningeal artery is probably very targeted to focal inflammation with the steroids. So adjustment, like that's from the chat. Now, another question is, in your treatment of aneurysmal subarachnoid headaches and the Bulgarian registry, did the patients receive only intra-arterial lidocaine or did they receive other pain medication?
Very good question. We actually collected, giving other medication was not prohibited, but we collected who got it. So as I showed that extensive use of opioids or 3 or more medication was only in 3 of the 58 patients. So essentially, we didn't collect, we actually have data, we haven't analyzed it, so we should have the data soon. But actually, multiple drugs were only used in 3 of the 58 patients.
A few more questions. What are your thoughts on unilateral versus bilateral treatment? And what about lidocaine versus longer acting agents such as bupivacaine?
So this is actually a very good question, and it's a very important question that, why not use something longer acting? Because there's definitely longer acting amides, and the whole premise of longer acting amides was to prolong the therapeutic effect of these anesthetics and amides. And we haven't used bupivacaine, which is a longer acting agent. And again, when we went on the research development side, the options were take lidocaine and make it into a sustained release preparation, or actually start experimenting with longer acting agents. But we thought that sustained release lidocaine had a better potential because even with other longer acting amides, the effect is really up to 24 hours. You don't really have an effect up to beyond 24 hours. With the sustained released preparations, you could actually have effect that may go all the way to 1 month. So that is the direction we took in terms of moving forward with research and development. But actually, it's a very important question, and it's quite possible that we may pair sustained release with some of the other agents rather than lidocaine. It just was a little, it's pharmacological, a little easier to create a sustained release lidocaine. It had some technical issues, but it was a little easier agent to do than bupivacaine or some of the longer acting amides.
We have one more question, and it's related to the prior question on medication overuse headache. So why not include patients with medication overuse headache in the study and evaluate their response to treatment as a subset, which kind of will emulate the real world scenario?
I think that you brought a topic very close to my heart, and I will say why. Just almost a year ago, we wrote a review article on pragmatic clinical trials in Annals of Neurology. And it all comes down to real world. So you can so you actually have a competing interest. So on one hand, you want to do these explanatory clinical trials in a highly selected group of patients with a very selected settings. But on the other hand, you want to apply this to the real world where they have all these issues. So you have a psychological component, you have medication overuse, medication tolerance, and whether our clinical trial should actually really get more closer to real world using a pragmatic design. And this is a very good suggestion, and we will definitely take it into consideration. I have been actually totally advocating for what you're saying. Go more pragmatic. But it seems like many of the people on the funding agencies still are actually more convinced with the explanatory, more specific trials, at least as the initial goal.
Well, thank you. I mean, this remains a big problem with headache treatments, I would say. So it seems reasonable to also evaluate them. All right. Well, I think that was our last question. Well, thank you so much. That was very fascinating and interesting. And thank you for having the time for being with us this morning. For all our viewers, please, again, if you didn't get the chance to see the CME code, check the webinar chat. The CME code and the phone number to text is in the chat box.
Well, thank you so much for having me. It's always a pleasure. I was actually telling that I was actually at your hospital many years ago. So, it's actually great to actually connect again and have this opportunity. Thank you so much.
Absolutely. No, thank you for, again, your time, and hopefully maybe we'll see you in person next time.
Yes, absolutely.
All right.
Bye now.
Have a great day. Bye.